Dr. Ashley Weedn earned her medical degree from the University of Oklahoma College of Medicine and completed a pediatrics residency at Arkansas Children's Hospital. During residency, she trained at the University of California at San Francisco in pediatric weight management. She returned to Oklahoma in 2010 and joined the Department of Pediatrics at the University of Oklahoma Health Sciences Center as the first general academic pediatrics fellow. During her fellowship, she obtained a master's in public health at the OU College of Public Health in 2012. She's a board-certified pediatrician and an assistant professor in the section of general and community pediatrics at the University of Oklahoma Health Sciences Center. Dr. Weedn serves as the medical director of the OU Pediatric Multidisciplinary Weight Management Clinic, known as Healthy Futures. She co-chairs the National Obesity Interest Group of the Academic Pediatric Association, and she serves as a childhood obesity advisor for the American Academy of Pediatrics. She also founded and co-chairs the Obesity Committee through the Oklahoma chapter of the American Academy of Pediatrics. Please help me welcome Dr. Ashley Weedn.
Thanks, Tim, for the introduction. And thanks to the committee for organizing this great conference, and for all of y'all for taking your time out on Saturday to be here and your interest in addressing obesity in your practice and in your communities. So as Tim mentioned, I'm a general pediatrician by training, and just kind of y'all are welcome to ask questions throughout my presentation. How many here are providers? How many are physicians in the audience today? Okay, so about half. And then of the physicians, mostly family practice, okay. And then other allied health professionals, dietitians,
We have some
nurse practitioners, anyone else, physical therapy, okay. Social nursing, okay, social, okay, just to kind of give me an overview. So I'm going to, for the first presentation, talk about obesity in the primary care office and build on Dr. Rose's excellent talk on of giving an overview of assessment and management. So let me get this working. So I have no disclosures to report. So despite the fact that 1 in 3 children are overweight and obese, the studies really show that there are significant gaps in the management of obesity in primary care. So studies have shown that pediatric providers often don't utilize BMI or BMI percentile, and often will kind of judge overweight by visual. And as Dr. Rose pointed out earlier, that's not always accurate. So the other barriers, clinicians report low efficacy and confidence in managing overweight and obesity. And so this is nationally, whether they're family practitioners or nurse practitioners or pediatricians, there's been several studies reporting kind of low efficacy and confidence. In our state, in Oklahoma, the Oklahoma chapter of the American Academy of Pediatrics, we surveyed all of our members and asked them about their practices and attitudes related to taking care of overweight and obese kids. And what we saw on the survey was that really it was all over the place. So there was a high interest in doing so, but as far as the management practices, few were aware of kind of guidelines. Additionally, the kind of the assessment for comorbidities, the laboratory tests were all over the map and what was being ordered. And then over 60% reported that they don't feel proficient in doing any kind of behavioral management because our training is really traditionally and historically we don't have a lot of training in behavioral management in our medical schools. So they reported time as well as patient and family barriers and lack of training in overweight and obesity management. So hopefully we're addressing one piece of that today. The learning objectives then are to identify overweight and obesity in the pediatric population, to perform a medical assessment for overweight and obese children, and then to recognize the national recommendations for pediatric weight management in primary care. And so to address these gaps and aid in the care of overweight and obese children, the American Medical Association, in conjunction with the CDC and the Health Resources and Services Association, brought together representatives from 15 different organizations, and that included the American Academy of Family Practice and the American Academy of Pediatrics and the Endocrine Society come together and provide both evidence-based and expert opinion recommendations to help providers in primary care manage and assess obesity. So this occurred about a decade ago, and the recommendations were released in 2007, and they focus both on assessment, prevention, and treatment. They provide an algorithm for management of pediatric obesity, identifying, with the first one being identifying it by BMI category, and then performing a thorough assessment of behaviors, both dietary activity, the medical risk for comorbidities, as well as the readiness to change behaviorally. And then they stress prevention, and they provide a staged, stepwise approach to management in primary care. So we'll be reviewing each of these. I know Dr. Rose talked about some of this. The step one on assessment of BMI, I'm sure y'all are already familiar with. The key here in kids are that we use the BMI growth charts. And so absolute BMI is not pertinent for the kids because they are growing along the spectrum. So we have to, it's gender specific, it's age specific. We plot it on the CDC growth chart. And we start performing these every year at the Well Child Check starting at age 2. And the reason is to track it over time and to look at crossing percentiles. Before age 2, the recommendation is to use the World Health Organization growth charts. And really, the literature is really coming out that identification as early as possible is key to this. And so, even in the kids less than 2, seeing where their weight for height is on the growth percentiles and tracking those kids early on and offering kind of preventive counseling recommendations is key. So this is the growth chart that Dr. Rose provided to us earlier. And so overweight is the 85th up to the 95th percentile, and obesity is defined as a BMI greater than or equal to the 95th percentile in kids. And so it's not a perfect measure by any means, but for several studies have shown that a BMI of the 95th percentile in kids, it really does correlate with adiposity. And not only does it correlate with adiposity, but it correlates with adult adiposity. So children who are at higher BMI percentiles over the 95th percentile tend to track into adulthood. So as well as their cardiovascular risk factors of long-term mortality. The higher the BMI percentile, the more risk there is for comorbid conditions starting in childhood, as we'll talk about. And again, here's just the definitions. So moving to assessment, it's in the history. We want to do a thorough dietary, physical activity assessment, and these are to identify targets for behavioral change, as well as a family history, review of systems, and physical exam to assess risk for comorbidities. So for the dietary assessment, kind of the recommendations are to do a broad dietary assessment. So I am a general pediatrician. I supervise the residents in my general pediatrics clinic, and so during our well child checks, there's only so much time for a well child check, and they'll come in and I'll ask them about their dietary history, and it's like, oh yeah, they do eat fruits and vegetables. I'm not sure for sure what they're drinking. It seems to be a very limited time to do a broad dietary assessment. And so the recommendations are really to try to do as thorough as possible. So for beverages, really getting an idea of not what they're drinking, so not just sugary beverages, but how much of those sugary beverages are they drinking, what types of sugary beverages. Is it, are you only asking about soda, are you asking about juice, are you asking about Gatorade, sweet tea where we are in the South, trying to get an idea of the spectrum of the beverage intake and the amount of sugar sweetened beverages. Are they drinking water? Have they ever tried water? And what that how much of that they're doing. Breakfast. So looking at meal patterns. So are they eating 3 meals a day? How many snacks are they eating a day? The frequency. If they're having family meals together. So are they getting fast food? Are they having structured time to sit down and have family meals together? Or are they eating in front of the TV? Are they eating at different times? We've had families, the kids are eating in the room in front of the computer at different times than the parents. And when we counsel about, Dr. Gillespie always has a great story when we counsel about trying to do family meals together and not eating in front of the TV. So they came back and they were say, yes, we're doing family meals and we're not eating in front of the TV. And as we asked more questions about if they're sitting down together, they were sitting down together, they just weren't facing the TV. So it was still on the couch, the TV was on, but the TV was in the back of them. And so really having that conversation about what the environment is that looks like when they're sitting down for meals. Portion sizes are important, as well as getting an idea of the types of foods and the quality of foods that they're eating, such as the fruits and vegetables, the energy-dense foods that Dr. Rose mentioned, and fiber. So, and then for physical activity assessment, for also getting an idea of like just what types of activities they're doing. If they're preschool or school-age children, how much time do they spend outside? What are they doing when they're outside? Do they have any sports involvement or organized activities? If they participate in PE, so not just if they have PE, how many times a week they have PE, but do they participate? We have some kids that aren't able to participate due to their weight, and so they're kind of sitting out on the sidelines. So you'll get a report that they're in PE, but they're actually not being active in PE. If they're doing video games, or is they just sedentary video games, or are they being active in their video games? The amount of screen time, whether that's TV or computer time or iPads or iPhones, looking at if there's TVs in the room, that's been associated with obesity and weight gain, as well as the built environment. So a lot of the kids aren't able to, they can't just go play outside because it's not safe for them to play outside or ride their bike down the street. So that's a lot of questions to ask, right? And in a well child check, that's difficult to do. So kind of one of the resources that the AAP has put out with the 5210 and Let's Go is this Healthy Habits Questionnaire, and it's broken down into ages 2 through 9 and 10 through 18, and it's actually available in your flip chart that you got with the 5210 flip chart. Have any of y'all seen this before? Anyone? Okay, so a couple of people. So I think this is a great resource because it sets the stage to go ahead and get those behaviors. So if you give that out as a part of the well child check and that's already completed, then you have a lot of that information, and then you can follow up on all the details that were in the previous slides. So if you walk through it, already ask about if they're eating fruits and vegetables, how many times they're doing family meals together, if they're eating breakfast, how often they're eating out or doing fast food, how many hours of TV a day, or if they have a TV in the bedroom. Is there a computer in the room where the child sleeps? Again, getting at that screen time question and how much they spend in active time, as well as the sugary beverages, and it kind of lists out different beverages. And I think the key thing on this questionnaire is not only does it ask for that assessment, but then it asks this question, is there anything you would like for your child to change? So it's already setting the stage for the parent to think about, oh, maybe there is something that I would like to change. And I feel like it really helps facilitate that conversation. So I think it's a great tool for primary care. And then for risk factors, as taking assessment of personal risk factors, Dr. Rose talked about a lot of these. So prenatal factors. So I think this is important for the kids that you're seeing, the newborns and the infants, to keep in mind, so that if you take a prenatal history and there's maternal obesity and maternal gestational diabetes, maternal smoking during pregnancy, all of which we know are associated with obesity, then really, promoting breastfeeding, talking about introduction of solids, talking about juice early on, before they're already implemented it, and starting healthy behaviors at the earliest stages. And then after a prenatal period. So large for gestational age, small for gestational age have both been associated with obesity. Again, breastfeeding seems to have a protective effect. And then rapid weight gain during those first 2 years of life. BMI at 1 year of age, or excess weight for height at 1 year of age predicts later obesity. So tracking that early on. Ethnicity plays a role, so minorities have higher risk for overweight and obesity, as well as comorbidities. In Oklahoma, I work with the American Indian tribes a lot, and there's a piece of this that's culturally based. It's not just genetics, but there's a cultural component, and really having learning the skills to have, when you're making recommendations, to take into effect what their culture is. And we'll talk about that as we go through the management piece. Medications can play a role, and then more and more studies are showing the role of sleep and the lack of sleep in regard to the association with obesity. So addressing sleep as a part of both assessment and management for our kids, both preventively, but for our overweight and obese patients too. So family history risk factors. If one parent's obese, there's a risk, and it increases quite a bit when both parents are obese. If there's family history of type 2 diabetes in a first or second generation relative, mother with gestational diabetes, anyone with hypertension or high cholesterol, and family members with heart disease or stroke. So I try to get an assessment at that well child of which of the family members, kind of first and second degree relatives that have these types of conditions, because that's going to put that child at greater risk for comorbidities with overweight and obesity. Targeted review of systems, so for your obese patient, overweight and obese patients, going ahead and starting that assessment for comorbidities and asking, I put this as a targeted, but chest pain to look at, is the chest pain, is it esophageal reflux? Are they having burning chest pain? Are they having chest tightening for asthma? What's their exercise tolerance look like? Are they snoring? Do they have signs of sleep apnea, which we see in a lot of our kids? From an endocrine perspective, looking at, for our teenage girls, PCOS, so looking for symptoms of PCOS, polydipsia and polyuria if they're if they're close to the spectrum for diabetes. Cold intolerance, again, we talked about a little bit about hypothyroidism before. It's really not a big contributor for obesity in children. I would say like less than 5%, maybe less than 1% are for the majority of cases with obesity. Most of the kids we see are tall, and so if they are, it's more of a concern for short stature that you want to be thinking of hypothyroidism. Abdominal pain that can be related to reflux, our fatty liver disease, our gallstones, and then doing a thorough kind of asking about joint pain, hip pain, back pain, foot pain, knee pain that can limit activity, asking about history of headaches that could be related to sleep apnea, that could be related to pseudotumor. Sorry. So it depends on a couple of different things. So we will, on exam, if it depends on the age of the child and on exam. So if they have tonsillar hypertrophy, a lot of times I'll go ahead and refer to ENT. For my kids, so in primary care, I'll go ahead and refer to ENT and have them do an assessment. For tonsillar hypertrophy, and a lot of times they'll move forward with a TNA. In the weight management clinic, I do a baseline sleep study. So I want to know where they're at, even if they have tonsillar hypertrophy. And so we'll then send to ENT, and they'll typically do a TNA. If there's not, if they've already had a TNA, then we're doing CPAP management. And so I have kids as young as 4 on CPAP. So it is. We see this early on. I always do this in conjunction. We have a sleep medicine expert in the benefit of being at an academic center is all the subspecialists are right there. And so we feel like it's critical because sleep disturbance does play a role with obesity. So sorry I missed your question. We all can wave higher next time. Go ahead. Mm-hmm. Yep. So our Medicaid now requires prior authorizations, whereas before it didn't, but now it does. So we haven't had any real issues with insurance. The issue with insurance comes when the kids are already on CPAP and their compliance with CPAP. So if they are not compliant with CPAP, then they take the CPAP machine away after about 3 to 6 months. I don't know if that's true here in Kentucky, but we have that is our biggest barrier. So before we ever do CPAP, that's why we have a team. We're working with psychology. We're talking about kind of the why we're treating the sleep apnea and how to go about that. And even we do exposure. They'll just wear CPAP for a little bit of time, day to day, and increase that over time. And so to try to get them used to wearing that, because it's a big difference to not be wearing anything to all of a sudden be wearing this appliance on you for overnight. So we do address that. We don't have Medicaid issues with that. And again, we try to be proactive in addressing the compliance so that it's not taken away. That being said, that does happen, and then we have to go through the whole process again. And then there's the psychosocial, taking a history regarding psychosocial concerns. For physical exam, we always, in primary care, always doing kind of a complete physical exam, starting with the vitals, making sure y'all are getting the blood pressures to look for elevated blood pressure, hypertension, looking on exam for signs of insulin resistance with acanthosis. It should be hirsutism for the exam finding to assess for PCOS. A few cases for I've seen two, a pseudotumor cerebri with papilledema. So if they have a headache, then following up and doing a fundoscopic exam, especially if the headache has symptoms of elevated ICP. So we actually see a lot of headaches in our obese population and in our multidisciplinary clinic. So obviously not all of these are pseudotumor. There's an association with migraines and obesity, and so it's really those headaches that have ICP symptoms, so positional headaches, vomiting with headaches, but doing a fundoscopic exam. And then we talked about looking at the tonsils for obstructive sleep apnea, and again, not abdominal pain, but feeling if they have any hepatomegaly on exam. If they are short stature, then going ahead and looking at possible endocrine workup for hypothyroidism or Cushing's or Prader-Willi, depending on what other symptoms and signs they have on exam. And then doing a good musculoskeletal exam to look for things like SCFE, or if they have bowed legs, Blount's disease. And all of these, I do another presentation later where I'm talking about kind of the assessment and management of comorbidities. But this is for in the primary care office, going ahead and starting that workup. Obesity affects every single system and so that's why we do kind of a thorough assessment and exam. And so for the laboratory evaluation, this presentation is based off those 2007 recommendations. So for kids that are over 10 years of age and who are obese, so greater than or equal to the 95th percentile, getting a fasted lipid panel, a fasting glucose, and liver function test. And that is really because these are insulin resistance and dyslipidemia. I mean, they're asymptomatic typically, and so you want to kind of have, a lot of our kids have these, and being able to provide that information to the family. It also helps with management. You're having the conversation about improving your child's health, not about weight, and this is one of the ways to be able to address that. Also, if they are overweight with 2 risk factors, so those risk family history of dyslipidemia or diabetes or their ethnicity, or if they have any personal risk factors for comorbidities. And then if they're overweight, just getting the fasted lipid panel. And as far as the age, so this is a little bit, so the Barlow recommendations are greater than or equal to, so starting at 10 years of age. Before 10 years of age, and I don't know if Chris will talk about this during his talk, but there's some, there's no set guidelines per se, but the American Heart Association recommends for overweight and obese kids to go ahead and start getting those fasted lipid panels to be looking for dyslipidemia. I've had a lot, when I do CME talks, a lot of the physicians say, well, why would we ever do a fasting lipid panel in a 4-year-old? Like, what are we going to do with that? We're not going to put them on medicine. I don't see why we would do that. And my answer is, because we're seeing a lot of dyslipidemia in 2-year-olds and 3-year-olds and 4-year-olds. I see it, every week in clinic. And so that's powerful information to give back to your family so that it's not about weight. It's about their health. It's already affecting their triglyceride levels. And so I think that that's the role that it can play. But again, those guidelines are set, so are not consistently set. And we can have a discussion about that a little bit later. And then the final assessment is on the readiness to change. So, asking the parent and patient about open-ended questions about their health and weight. And so doing this, do you have any, during the well-child check, do you have any concerns about that child's health? And I put it in the perspective of health more than weight, although I will address weight, but I always start with health. I show them the BMI growth curve, and I say, when you're above the 85th, and especially above the 95th percentile, you're at increased risk for long-term complications. And so do you have any concerns about that? Or is there any specific concerns related to weight? But I always try to make it about health. And part of that is because the studies have shown that parental perceptions of overweight children, like few even recognize their children are overweight. So like the study by Eckstein and Pediatric showed only 1 in 3 parents recognized it. And as the previous presentation had said, providers have a hard time recognizing it too. Parents may not be worried about it, and few remember that their pediatrician or family practitioner ever talked about it. So I think it's really important to have those conversations, show them the BMI growth curve, and actually talk to them about, do they have concerns related to their health, and start that conversation that way. I know the previous presenter said a lot of times she won't bring it up in that first visit. I try to do this at the end of the well child. So I'm getting the whole, doing all my well child check marks, right? And then at the end, I'm like, let's talk. I want to spend some time talking about your child's growth, and let me review the growth chart. And what do you think about that? And do you have any concerns? And if there's no concerns, may I share some information? And so we'll talk about that on the next slide. The key here is kind of choosing language carefully to make sure you continue to have the rapport with the family. So I do focus. So I'm 80% research. I do a lot of focus groups with the Oklahoma tribes, and there have been studies on this too, as far as what's the best terminology. Obese can be offensive to some parents, and so the studies have shown unhealthy weight. Some families want to be told directly, like, yes, my child's overweight, but the manner in which we do it, how we share that information, if we're asking to share that information, I think plays a big role in how that's received by the parent. So most of you are probably familiar with the stages of change. So there's 5 stages: pre-contemplation, contemplation, preparation, change, and maintenance. And Dr. Gillespie may be focusing more on this during his talks with motivational interviewing. But a lot of times, this is what I try to figure out where they are. I try to meet them where they're at. So if I am talking to them about kind of their growth curve, and they automatically say, do you have any concerns about your child's health? No, I don't have any concerns. She may be bigger, but we all are. She's big boned. Her weight is fine. I'm not concerned. Like, if there's 0 registration, that to me it means that they haven't really been thinking about it. So I'm going to ask to have a conversation about it by showing them the information on the growth curve, and following that up and say, hey, a lot of kids that are above the certain BMI percentile, they can have things like, higher cholesterol levels or higher triglyceride levels. And let's go ahead and check that. Especially, I get a family history. A lot of these kids have a family history of cardiovascular disease, and so that just strengthens it. And sometimes I'll bring them in with the family history, be like, the parent will say, oh yeah, my dad has had a heart attack, and yeah, actually I'm worried about a heart attack, not about the child's weight at all, but about that heart attack. And I'm like, yeah, well, let's go ahead and do some lab work, and then that way, at the end of the child check, I have a follow-up appointment. They're going to go have their labs done. They're coming back. I'm going to go over those labs with them. And then what I'm going to also do during that time is that allows for a whole visit for me to talk about health behaviors and changes, and to kind of contract with them on where they're at and setting goals. And then, but based off their answers, you can kind of tell where they are if they've thought about it. Contemplation, an example might be, yeah, well, she's bigger, but she's gained a lot of weight, but she'll outgrow it. And we see this a lot of times, kind of early school age. She'll be fine. She's going to grow out. She'll hit puberty. She'll have her growth spurt. And so they may be recognizing that they're bigger, but not necessarily in any place they want to do something about it, because it's going to be taking care of itself. She's going to grow taller. He's going to grow taller. And so having that conversation, that a lot of times our kids, when they're at the higher BMI percentiles, they continue to track along those higher BMI percentiles, and then sharing information Again, getting at the family history, getting the lab work to look at where it's not about what BMI percentile they're at or about what weight they're at, but about their health and talking about healthy behaviors. And then, so in primary care, I feel like a lot of my families are at the pre-contemplation, contemplation, and a few are at the preparation standpoint, but most of them are in the pre-contemplation, contemplation. And I feel like it's my job as the pediatrician to have those conversations with them, because every conversation can lead them from pre-contemplation to contemplation. I feel very fortunate in my weight management clinic that our families that are coming into a weight management clinic, because of our referral criteria, they're coming in their preparation or change stage. They've already started making changes. They've been working with the primary care provider to make changes. So I have a huge advantage in that clinic because they're coming in and they're ready. They just need assistance and they know what to do. They don't know how to do it. They need help in implementing those changes. And so we have a team to be able to help with that. But I really feel the key piece for primary care is trying to help the family move from one stage to another, more than just giving them, here's where your child's at and here's a list of recommendations. I feel like it's my job to help facilitate that conversation to move them between stages. So again, we wanted to determine the level of intervention based on the stage of change. So what then after assessment, what do we do? Well, the overall goals are to enlist behavior change and empower parents and patients to do that in order to improve their self-esteem and self-efficacy, with the outcomes looking at reducing BMI velocity and preventing or reversing comorbidities. So I feel like, a lot of our families come in, and so if they do recognize weight, it's about, in our multidisciplinary clinic, they still come in. We need her to lose weight, or we need him to lose weight. And so it's having that conversation about, this is about health. We're working on trying to either reverse the comorbidity that they were referred to, or prevent those comorbidities from happening. And if we implement these healthy behaviors, the byproduct's going to be, they're going to probably reduce their BMI velocity, or at least stabilize their BMI. And so we have an upfront conversation and repeat it every single time that this is not about weight loss. If they've been gaining, most of the kids that are referred to our clinic are gaining about 30 pounds per year, between 30 and 40, some up to 50 pounds a year. And so, really, to sit there and say they're going to be gaining weight like this and then all of a sudden do a huge weight loss, it's not realistic. And so if I can talk to the family and give them feedback after 6 months that, before if they were gaining 15 pounds over six months and they're gaining 7 over 6, that's a success. And we need to share that information with the family. So I always track what their weight velocity is, and that is my key feedback that I give to parents. It's not, they weighed this much and now they weigh this much. I talk about in terms of weight velocity and BMI velocity. And I think that helps reframe it for parents as far as, so they don't need to be, I don't need to, because I think the first thing they do is they get to the office and they step on that scale and they're looking at that number, and then you can sometimes see it in them. They feel let down. They feel like they failed. And so just reframing it to be like, no, look, before you were gaining at this rate and now you're gaining at this rate, and that's an improvement. And so we really focus our outcomes on those as well as lab improvements, and with the key being, are they meeting their goals? Because if they're meeting their goals, they're going to have these long-term improvements. So the recommendations are to base the intervention on the stage of change, using a patient-centered agenda, through effective communication and assessing their confidence and importance in being able to make those behavior changes, and involving every single member of the family. And the goal is to negotiate for a family change through motivational interviewing. So before this presentation, I know Dr. Thornberry's here, but how many of y'all have heard of motivational interviewing? Any? So actually few of y'all. Okay. So you have a whole afternoon dedicated to kind of going over motivational interviewing, but just to kind of give an quick overview right now, it's really the preferred method of counseling for obesity management. It's client-centered, directive method for enhancing that intrinsic motivation to change by exploring and resolving their own concern, their pros and cons of change. So this is the case in that, typical setup, how I was trained, at least in medical school, you go to your physician, they're going to tell you what to do, right? And so you need to not drink sugar-sweetened beverages. You need to not be eating out all the time. So trying to figure out for that own patient and family, what would they like, what are their goals, and what are their motivations and values behind those goals. And so that's the center of motivational interviewing, where it's not about the physician providing recommendations, but it's about listening to the patient or the parent, or together the family, and finding out what their motivation is. What's the barriers for them? What are the pros and cons? And they basically can self-talk themselves into, here's where I am, and maybe I could make a change. The goal is to facilitate a fully informed, deeply contemplated, and internally motivated choices so that behavior change will follow. So just to give a comparison of usual practice versus MI. So in usual practice, the clinician can set the agenda and tell the patient kind of what's important, and the clinician decides when to move ahead with the goals and is responsible for making the patient goals. The clinician's the instructor, and success is measured by weight loss and change in the physical measures. Whereas in motivational interviewing, we really have the patient set the agenda, the patient decides what is important and in line with core values, beliefs, and needs. The patient sets pace for the work, and the patient is responsible if and when the behavior change occurs. And the clinician is simply a guide in this process, and success is measured by the patient's own values and goals, and not by our values and goals and just looking at weight loss. The notes that I receive, so I review all of the notes of the kids that are referred to our clinic, and so I so commonly see, even in the HPI, patient returns for a weight check, no weight loss. Our patient returns or in the assessment, no weight loss, and I told them to do, X, Y, and Z. And so that may not be what really happened. That's just what is in their note. But how that comes across to me when I'm reading it is, okay, this is, we need to empower the family to make their own goals, and then how we track those goals. Are they following up on those goals versus is it about a weight change per se? So what are some of the targeted goals? So you're in primary care. You've identified that you have a child who's overweight or obese. You've talked to them about it. You've asked them, how they feel about their health. If they're ready to make a change, then what are the changes to recommend, and what's the evidence behind it, and what are kind of first step, second step, and third step. So the Barlow recommendations provide multiple different recommendations. When we give CME talks, I frequently have physicians say, or nurse practitioners say, well, we know what to say as far as sugary sweetened beverages, but we really don't know what to say after that. Like, how do I really give them information about changing other dietary habits? And so these are some of the ideas, and then there's resources that go behind these ideas to help you implement that in primary care. So for dietary intake, limiting sugary beverages, increasing fruits and vegetables, addressing eating behaviors through talking about meal frequency. If they're skipping meals, a lot of our adolescents are skipping meals on a regular basis, and so kind of talking to them about the importance of meal regulation, talking about portion sizes and showing portion sizes specific to the age, if the family's eating meals together, how much they're, as far as eating out. For sedentary behaviors, talking about screen time, setting goals around screen time, or removing TV from a child's room. For physical activity, increasing their activity. And so the ones that are listed in bold are the ones that have more consistent evidence versus the ones not in bold that have kind of equivocal. So some studies say, yes, it really makes a difference, and other studies say not so much. So in doing this, kind of setting the agenda working with the parent to set the agenda for setting dietary goals, I feel like if you've brought them back and you have labs and you're having a conversation about, what the nice thing about the 5210 questionnaire is the family may already have a goal in mind. And so you build off that goal. That would be idea. But a lot of our families will say, oh, I've tried this, I really don't know. What do you recommend? So it's okay to provide recommendations. You can, and just let the family choose. So you can talk about, after you've taken a target, a history, is it juice intake? Is it that they're skipping meals? Are they eating out 5 times a week because of busy schedules? Is there 0 fruits and vegetables? Are there portions? Is the mom saying, oh, they're always having second portions or third portions at every meal? Are other ideas based off what that history is? So I feel like it's okay to present options if the family doesn't have ideas in mind, and then working with the family on what would they be able to implement that the whole family would be able to implement. Maybe it's not realistic to cut down sugary beverages or juice because there's someone in that family that is, they are not going to be on board with that. And so we talk about that. What are the barriers to implementing one of these, and then how do we go about that? And so that conversation may lead where they've started to say, oh, I want to talk, I think sugary beverages. She drinks a ton of sugary beverages. There's soda, there's juice in the house. And then having a conversation, okay, so how are we going to do that? So, we're not going to buy sugary beverages. We're not going to bring it in the home. Oh, well, Dad will never go for that. He's a Coke fan. And so having a conversation, well, what do you think? Do you think he would buy into that or not? And if it's off the table, if they really don't feel like that, then maybe that's not the best goal right then. Or maybe they want to go ahead and do it, and then they come back and it didn't go so well. And then that leads an opportunity to have a conversation about, well, how do we need to adjust that? Can we bring Dad into the appointment next time? Or do we need to choose a whole new goal together? So I feel like it has to be a realistic goal that the whole family can incorporate, because if we're only doing it for a child, it's not going to work. And role modeling is key here. The goals need to be SMART goals, so specific, measurable, attainable, realistic, and timely. And so instead of eating less, fast food, making that as specific as possible. I'm going to limit fast food to once a week, even maybe potentially when that's going to be, why it's going to be, but kind of contracting, having them think through that instead of just saying, oh, I'm going to reduce sugary beverages. Talk about what that looks like for them. How are they going to implement that? Because a lot of times the families know what to do, they just don't know how to do it. And so walking through how to implement some of these recommendations. Same thing for physical activity. There's lots of different options depending on what that kid's history looks like. A lot of time we'll see that maybe they're active at school, so they do school. Maybe they do participate in PE and they do school-related activities. But on the weekends, there's nothing. It's TV all weekend, and so we really try to incorporate family activity as well. So it's not just about the child needs to be doing this. We have lots of families that come in and be like, oh, I send my child to the YMCA or, so many times a week, but again, that role modeling, having the family activity. So we all often try to work on having family goals, whether it's walks to the park together or, riding bikes together or something that the family would all want to do together. And then sleep goals. So, as I said, sleep is, short sleep duration is associated with obesity as well as sleep disruption. And so you also, a lot of times, we'll set goals around sleep. And so if there's, TV in the room or electronics in the bedroom, we'll talk about that and how that may be disruptive to the sleep and how that can be associated with obesity. So maybe we're focusing on which is not a diet or activity goal at all, but maybe that's what they feel like they can do. And then increasing the duration of sleep. So I've provided from the National Sleep Foundation the age-based sleep guidelines that were updated last year for all ages of children. And so I think some of these can be hard to reach, and so just gradually working to increase the hours of sleep. And then negotiating a contract. So you want to involve all members of the family in this if you can, and that's what I was saying. When you're having a conversation about what behavior they want to focus on, asking if all members would be behind that, or if there is a particular member that that's off the table for. if it is, and that you feel like that's a really important one, and even the parent that's there feels that's really important, then asking for that family member to come in. A lot of times we have where both parents are bringing the kid to clinic, or one parent is, but the child's with grandmother after school, like all afternoon, and so then we all say, let's bring grandmother in and talk about this. And this is especially, I think it's true regardless of your culture, but again, we work a lot of times with American Indian families, and just having that whole family buy-in and talking about, what are some of the options that are healthier options in the grandparents' home, and why that's important for this child, because everyone's behind their child's health or their grandchild's health. They all want their children to be healthy, and that's a common goal that the family can get behind. So you want to have an engaged family, and typically we'll do, one dietary and one physical activity goal, and that's kind of what we try to do. But again, it's totally dependent on that family. If activity is not an issue, or that's not something they want to address, then we're focusing on what that one or two goals they are. But the reason I bring this up is we don't want to have a ton of goals, right? So frequently kids are referred sometimes to dietitians before they come to our weight management clinic. And so a lot of times when I look at the notes, there's like 10 goals for that family all at one visit. And so I think it's overwhelming when they leave with one goal from our visit, much less 10 goals from, and so, because it's hard to walk through all of how to implement that goal if you're listing off 10 different, and it's hard to make that many behavior changes. And so really trying to narrow that down as much as possible, instead of kind of listing off a bunch of goals that in reality, I feel like the family can feel like it sets them up for failure. If they're not able to meet all those goals, then that doesn't enforce self-confidence and self-efficacy. So the goal is to build the self-confidence and self-efficacy and make it a manageable and doable goal. So there are actually prescriptions. So I feel strongly about, we give prescriptions for antibiotics for an ear infection, and the family feels, they're walking away with something. So I feel strongly that we need to have a prescription for the health behavior, because it is an intervention. It's a management that we're doing. And so I like to walk away with the prescription with the family. Our kids, we ask them to hang it on their refrigerator door so they see it on a daily basis. We have our own prescription for our multidisciplinary clinic, but in primary care, I'll frequently use the prescription for healthier eating through the Let's Move campaign. How many are familiar with 5210? So a few of y'all. So for those that are not, 5210 is 5 fruits and vegetables a day, 2 hours or less of screen time, 1 hour of activity or more, and 0 sugary beverages. And this was an initiative that was put out through Maine and adopted statewide. And so there's been lots of resources from that. Oklahoma has actually adopted a 5210, so our coalitions are trying to kind of have a consistent messaging. I think messaging is so important. If you hear, from one provider, to do this, and in the community there may be something else, I think we all have to, in the focus groups I've done with preschool age children, WIC providers are telling the families one thing, pediatricians or family practitioners are telling them the other, and they're not consistent. And so trying to have as much consistent messaging, that just breaks down the barriers for the family. It makes it, if you have a consistent message, then, it's reinforcement for the family. So 5210 is a common resource that's available, and so you can start there. If they say, oh, we want to do sugary beverages, then there's already a prescription for you that you can mark off and they can contract with. These are available in Spanish too on websites. So, so the overall kind of components of management are to set SMART goals, to encourage small changes, provide close follow-up, and reward successful behavior change, where the success is defined as the family meeting their goal, not ours, and not necessarily weight loss at all. That being said, I'm putting in the weight management goals that were put out with the 2007 recommendations, and it's by age and BMI percentile. But I think it reinforces that the goals really should be weight maintenance or decreasing weight velocity. And if they are losing weight, not to exceed it. So, for the teenagers, not to try to do fast weight loss plans, or so it's to see what a healthy, if they are losing weight, what a healthy weight loss pattern would be. And then finally, so management. We've talked about that. The algorithm provides a staged management that I wanted to walk through. So stage 1 is prevention plus. That is in primary care. That is with you. So family visits with a primary care provider to address behavioral goals through motivational interviewing techniques. And so this, the goal here is to actively engage the whole family in lifestyle changes and to support specific changes in small increments. You tailor the follow-up to the family, but when you're setting behavioral goals, if you don't see them for 3 months, that's kind of hard to follow up. I think it's helpful if you're setting behavioral goals to follow up as soon as possible to see what works and what doesn't work, and so to bring them back as quickly as possible. So, for example, if I'm doing a well child visit, I may not have the time to do all of this, so I'm wrapping up by addressing it, seeing if what health concerns they are, if they're overweight or obese, trying to bring that to their radar, asking for specific information if they're interested in having a conversation about it, going ahead and doing bringing laboratory assessment, bringing them back in and having a conversation about what those lab results show, and then I have a whole nother appointment that I can dedicate to, let's focus on these changes in detail and walk through kind of the what works and what isn't working for them. You do this kind of on a regular basis and if you don't feel like you're having success with the family, so they're just struggling with meeting their goals, you can progress to stage 2. And stage 2 is structured weight management. It just it's more tracking, more monitoring. You involve dietitians in it you want to have as many resources as possible for the family. And also, these families are making the changes in their own community. They're not making them in the clinic. So you want to provide them with as many community resources as possible. You want to do that in stage 1 with Prevention Plus, but it becomes more intensified in stage 2, where you're making sure they are connected with community resources. And again, doing kind of the close follow-up. And then if you don't feel that you're making progress, moving on to stage 3, which is comprehensive multidisciplinary management, typically by a team that can include, it's variable, a clinician, a dietitian. There may be an exercise component, physical therapist or exercise trainer, and then a behavioral component or social worker. And so providing more of an increase in intensity and support. So this could be, an outpatient weight management program where it's weekly visits over 12 to 16 weeks. It could be the actual clinic that you refer to that may not be able to follow on a weekly basis, but they're following more closely than you can in primary care, and they're followed by an entire team. And then stage 4 is really for the obese children with comorbidities or severely obese children who have failed the previous stages. It incorporates kind of that same multidisciplinary team with expertise in pediatric obesity, as well as there's a specialist these are academic centers. There's specialists that are available. There's continued counseling, but you may consider more structured diets or medications or potentially bariatric surgery. So. The clinical summary of the U.S. Preventive Services Task Force recommendations had recommended that in pediatrics we should be screening for childhood overweight and obesity, the interventions that have shown to be the most effective are those multidisciplinary interventions. We're starting to see some studies in primary care that are showing positive effects, and Dr. Gillespie, I know, will refer to that in his motivational interviewing talk, but the recommendation from the American Academy of Pediatrics is actually to begin screening as early as possible, so it's not age 6. Oh, and for the stage management, it's to begin as early as possible, so not necessarily stage 6. I have kids in my multidisciplinary clinic that are age 2. So really starting from the beginning, especially when you see, if they have those prenatal risk factors, if they, if they're crossing growth curve on their weight for height and on their growth curves in less than 2, if they're tracking up, starting these counseling as early as possible and having the conversations, and then and increasing that stage management as early as possible. We know the more impact, the earlier we have these conversations, the more impact. It's really hard to change, by adolescence. We've looked at attrition in our multidisciplinary clinic, and so we have we only have about a 40% dropout rate after 6 months, and so the ones that are most likely to drop out are the adolescents, right? So starting as early as possible can change their weight trajectory earlier and ultimately have more long-term success. So one of the barriers that has been cited in the studies and in talking with providers in our state has been coding and reimbursement. And so, how do you address that? And so, or how do you code for that? And so in Oklahoma, our children that are on Medicaid, we actually can bill for obesity, and we encourage our providers to do that. We want to be able to document it and make plans about that, because if it's not documented, it's hard to document the management with it. And so we recommend coding for obesity. I talked to Dr. Bowling, and he had said that Medicaid does reimburse for obesity here if you use the obesity diagnosis here. But some of our private payers in Oklahoma, Blue Cross Blue Shield or United, they do not cover the obesity diagnosis. And so a lot of times then I will code based off symptoms, our exam findings, our lab findings, or the comorbidity. So you have other options to do that as well. If obesity isn't covered by one of the companies, then we'll just change it to based off the symptom or the comorbidity or the exam findings. So those are some of the ICD-10. I had to update the talk to include the ICD-10 codes for kind of the symptoms and comorbidities that can present with overweight and obesity. And the coding resource there, I think, is from the AAP practice management resources, but I don't know if it's been updated to the ICD-10. I think it's still ICD-9 on that. Is that?
I believe it is.
Yeah.
And we do code for obesity, but we still have to do
The comorbidities.
Also.
Can you list obesity first?
You can, yes.
Okay.
And we're encouraging folks to do that, even though that's relatively new.
Okay. So that's what.
We're still fighting it.
Yeah, and so I feel strongly. I code for all of it. I code obesity and every single comorbidity. Now, I may not code for a symptom if I have other things, unless I'm following up on that symptom. So let's say they have, irregular menstrual cycles, and I don't know if they have PCOS yet, then I'm coding for that symptom, and I'm doing follow-up testing for the PCOS to see if I'm going to change that code to PCOS. But we tend to code for it all. I just know it's very state by state, but those are the ICD-10 codes for you.
So in the new one, there are some ICD-10 codes. This came out. We revised this right as that was all coming out, so it's not all up to date. But the basics for obesity are in here. The comorbidities are not yet.
Okay. No, and I was going to say, I think so. When I first did this talk, I don't know, 2 or 3 years ago, I had used the resource in there, the 5210 flip chart. It's a fantastic resource, and I think I had pulled some of from that. I have not seen the updated one, so it's great to have that. So speaking of resources, so I feel like whenever we travel to go talk to groups of providers and talk about, here are some guidelines that have been out there for about 10 years. Most of them aren't aware of it, so we kind of share with them what those guidelines are and then try to problem solve with them, what's doable for you in your practice. Like, what do you feel like the barriers are? So we did a year-long webinar series in Oklahoma with monthly webinars for our providers that are archived. So if they weren't able to make the webinar, they were like short 40-minute, actually 30-minute, because we allowed time for questions. They were interactive webinars to be able on a whole array of topics with obesity management. And so those are archived, and we don't have pre and post tests for them, as well as follow-up surveys. And the number one, so we ask, what things have changed and what things do you feel like you still struggle with. And so there's lots of things that we've had positive feedback about changing, using the BMI percentiles, coding for obesity, how they have the conversation, using motivational interviewing. So all of those have been listed as positive changes, but they still report barriers in time. And so that typically it continues to be the consistent barrier. And so I think it's a matter of having all those resources, at least for me, when I'm doing primary care, at the fingertips. If I'm using that 5210 questionnaire, then I already have a lot of the assessment, and I can follow up on that a lot easier than if I'm kind of going from scratch and asking all of those dietary assessment questions that I mentioned. So I like having that resource because I feel like it makes for a more efficient clinic visit. Secondly, there's the AAP, there's an Institute for Healthy Childhood Weight, and they have practice tools on there. And I'm happy, I can maybe send this, the resources to someone that could be emailed out to participants. And I'll walk through some of the tools that they have on their website in a minute. The 5210 Let's Go Maine, I talked about the 5210. They have a childhood obesity resource toolkit. They have toolkits for providers and for community, and so multiple toolkits that have lots of resources in it. NICHQ, the National Initiative for Children's Healthcare Quality, has community-based resources, which is, and as well as provider toolkits. It also has policy tools on there. And then I feel like every state kind of has kind of a coalition that has a website with some handouts. So, for Kentucky, I don't know, do y'all have a whole resource of patient handouts available on your website through the chapter or?
Through the department, through the chapter, and also through the Department of Health. It's Healthy Numbers for Kentucky Families. It's 5210 based materials as well.
Fantastic. So are all of y'all familiar with that resource?
Probably not.
Okay, so maybe you'll be talking about that. So, but knowing where those resources are. So I think it's really important to be aware of the state resources, but also, there's other national resources and knowing kind of if you need to supplement some of those resources. So Next Steps is one of the resources I talked about through kind of the AAP and NICHQ. It's a practitioner's guide for theme follow-up visits for their patients to achieve a healthy weight. And I think it's in the new updated 5210 flip chart. It wasn't in the initial one. There's a page describing the next steps. But it's a flip chart for clinicians to guide conversations with children and adolescents about reducing and managing weight. It basically provides planned visits designed to teach evidence-based weight management strategies. And so I had mentioned, if you're working with the family on choosing a goal and they choose a specific goal, so let's say they want to talk about improving food quality, or we eat too many processed foods, but I really don't know how to change that. Then there's the flip chart has a patient page where there's information for the patient, and it has a provider page. And so the provider page has information on that specific health habit, like how that may relate to obesity or some of the statistics behind it, but it also has how do you have a conversation about making change and what are ways to implement those changes. So I think it's a helpful resource in primary care to say, again, I've had a lot of providers say, I really don't know how to have a conversation about implementing each of these goals, and I think Next Steps helps facilitate that. Now, it is not a free resource. You have to order it. And so that, I think, is available through the American Academy of Pediatrics. A free resource that's online is Healthy Active Living for Families. This is a resource developed by the American Academy of Pediatrics Institute for Healthy Childhood Weight, and the goal is on obesity prevention and intervention during the health supervision visits, and it's focused on young children. So it's infants, toddlers, and preschool-age children. I love this it's an interactive website. There's actually an app for it, but it uses positive and strength-based messages. It's very simple. How they developed it was they did focus groups with parents of preschool-age children and toddlers and infants across the United States, and asked them, what messages would you like to hear during your well chat? Like, what's the information? How would you like it to come across? So it's developmentally appropriate because it's focused, it breaks down into baby, infants, and toddlers and preschool-age children. It's action-oriented, it's clinically guided, but it's also guided by the parents. And so what you can do, you can choose, the age group, whether it's the baby, the toddler, or the preschool, and then you can choose if you want to focus on the feeding. Then you hit that, and it'll say, okay, what are some of the desired behaviors for that age group? And so this I hit on preschool aged, and so one of the desired behaviors are healthy beverages, and so you can click on healthy beverages, and then what it does is it has these little icons up here, and so if you hit that first icon, it'll say, okay, well, you want to choose milk or water for your child's beverage. So what's the evidence behind that? So it gives you something to have a conversation if they're maybe not on board about healthy beverages. You're just giving them that information. They may still not choose that, that's fine, but at least you have kind of some information about why that's the healthiest choice for your child. The other icons, I think, are conversation starters, how to talk about some of the health behaviors. There's another one that, what are parents' resources for those behaviors? And so each kind of icon it walks through from a parent's perspective. What information would they like to know about that behavior? How would they like to hear about you talking about that behavior? What are some resources for that? And so that is a resource on the American Academy of Pediatrics Center for Healthy Weight website. There's also, go ahead.
Yeah, it's just, does anybody know what a widget is? So that Healthy Active Living for Families has a widget that we use basically it's a thing that you put on your own website that will direct people to that website from your own website. So we've implanted the widget on our website.
Oh, good. Perfect.
It gets patients there pretty fast.
So then you can go straight to...
Yeah, and we get out a card to families
Yep.
saying, here's how you get to Healthy Active Living for families for patients between 2 and 6.
And I think this is perfect. So this is a great example of, this is a resource that should be provided across providers, right? So for physicians, this is great during their clinical encounters, but also, for WIC professionals, they're having some of the conversations for the infants and toddlers, because again, it's that consistent messaging. And so, several families have said, I'm hearing different things between my WIC provider and pediatrician, or my Head Start and my pediatrician. And so I work with WIC and Head Start through one of the tribal organizations, and they've asked for some of these resources so that we can have kind of those consistent messaging. So we are trying to do that, trying to provide the resources that are out there for the clinicians out to the community providers so that so the parents are receiving one message. Same thing with the 5210, having the community organizations behind it, the providers behind it, and having kind of, I think Maine has toolkits, 5210 for communities, for providers, for clinicians, for policy. So I think it's helpful to have that consistent language across groups because we're all devoted to child health. This resource is a motivational interviewing training through the American Academy of Pediatrics. It's called Change Talk. And so basically it's a virtual, it allows you to role play. So it's really cool. So you'll hear about, so for many of you, you're hearing about motivational interviewing for the very first time today. So Dr. Gillespie is going to spend an hour talking about providing an in-depth overview of MI, but there's really not a lot of time to do a whole lot of interactive MI, which I think provides kind of the best example of what it looks like. How do you implement this in practice? How do you have that conversation? And so this allows for kind of that virtual role play. And then Dr. Bowling said this is being updated as well.
It's going to have a second edition out there.
That's really, that's awesome.
Breastfeeding and snacking behavior.
Because right now, what is it? There's one scenario. Is that right?
Right. With Ethan, who's pictured there, and it's about sweet drinks.
Sweet drinks. That's what I was trying to remember what the health behavior was. But regardless of what the health behavior is, you actually get to see how that conversation takes place and how you can help improve their efficacy by using the motivational interviewing. Kaiser also has an online education program. When I did my weight management training out in San Francisco, I actually had to do an 8-week motivational interviewing training with the psychology trainees. And so they had us doing a lot of the Kaiser online education program. So it was really helpful for me. We would role play for like 4 hours, and then I would be able to go kind of practice practice it on this online education program. And again, you actually get to choose what you want to say to the patient, so or the parent. And so because there's pediatric scenarios on that too. And so, the parent will say something, and it gives you options for what to say back, and you hit that option, and there's a bubble from that parent's head that will be like, she's crazy, or she, it kind of gives you the perspective of like, what is that parent thinking when you say that? And then if you change how you phrase, because you may have the same meaning, but if you change how that's phrased, then how that really affects what that parent's thinking and how you're motivating them intrinsically to engage with you. So both are really helpful resources. The AAP Institute also has PEP, which is Pediatric e-Practice. And so this is an app that allows you to make sure your office is kind of geared towards having resources available so that you can assess and manage pediatric overweight and obesity as efficiently as possible in your clinic, but also that your clinic's friendly to it. So, as simple as having, posters, healthy posters up. If you have the 5210 posters, what's your setting when they walk into your clinic? How does that reinforce what you're talking about with them with healthy behaviors? And so it's a resource that kind of takes you through how to make your kind of clinic atmosphere promote overall health behaviors. Is there anything more you...
So, yeah, this is on the AAP website. So if you're an AAP member, you just go to aap.org/PEP for pediatric e-practice to get all those resources out there. If you're not an AAP member...
Is it available? That's what I didn't know.
You can still be an associate member.
Okay.
It's pretty inexpensive to be an associate member to access it. But you might need to access it through one of your AAP members.
Yeah.
But contact us. We can get it out to you.
Yeah, I think I think it's nice because really you have to set your practice. Your whole staff has to be engaged in this process, and you really need. I feel like from the time the patient walks through that door to have kind of your setting kind of dedicated to this is about health. And anyway, I had looked at it once a while back ago, and it really kind of here's what you can do in your practice to make small changes to make the visit both more efficient and more visual aids.
And the American Academy of Family Practice also has a lot of good stuff on their website, too.
Okay, perfect. Question?
Getting back to the children with dyslipidemia.
Yeah.
Besides the diet, is that what you're recommending first, just watching the diet
Mm-hmm.
and exercise for so long a period of time? Is it for any age or any point you can start on medication, or is that
Yeah, so I am going to spend quite a bit of time on that in this afternoon, but the quick answer to that is 6 months of lifestyle intervention is the first line. And then actually for the kids that have obesity, the dyslipidemia, so for LDL, so if you're talking about medication management through statins for dyslipidemia, so the typical dyslipidemia in obese kids is high triglycerides and low HDL, not necessarily elevated LDL, although we do see it. And so, but for the LDL, it depends on how many risk factors they have, and it has to be pretty elevated. So we're talking about an LDL level greater than 130 with 2 high-level risk factors, which they already have hypertension or they're severely obese. And then if it's an LDL greater than 160 with 1 high-level risk factor and 2 moderate factors, where that is they have elevated blood pressure but it doesn't require medication, or their BMI is at the 95th percentile. Typically, what we see practically is that I see more of the high triglycerides, low HDL than I see elevated LDL. But when I do see elevated LDL, there is a fantastic response from the dietary. So almost all the kids that I see that have their LDLs in anywhere from the 130s to, I've had up to 170 about in the weight management clinic that are referred specifically for obesity and dyslipidemia. When I repeat those in 6 months, they have come down pretty significantly. So I think the first line works if you're able to get them in an intensive program. The second thing is I started one kid on a statin who was a teenager. The recommendations are after age 10 in conjunction with our cardiologist who continues to have a pretty high LDL, and he is morbidly his BMI is 95, and he has hypertension on enalapril, and he has oral glucose tolerance. So he has those high-level risk factors. So you have to take the whole picture. But yes, the NHLBI guidelines, which is National Heart, Lung, Blood Institute, in 2011-12, they put out recommendations for dyslipidemia and hypertension management for both dietary management as well as medications for obese kids. And so not before age 10. Starting at age 10, if you're not seeing improvement after 6 months, then there is a recommendation for it. So our key point, first is to measure BMI on every child beginning at age 2, earlier through the WHO growth charts for weight for height at each well-child check, to assess behaviors and comorbidities and readiness to change, to implement motivational interviewing techniques to elicit behavior changes, and to promote those changes in weight maintenance and focus really less on weight loss and focusing on decreasing that weight velocity or maintaining weight. Really the goal on a month-to-month visit for me is, are they just meeting their behavioral goal? And then, after I've been following them for a while, I give them feedback on how their weight velocity has done. There are the references. So the expert committee recommendations were published in Pediatrics in 2007, so they're almost 10 years old. I think there's, and then there's a new book out by Sandy Hassink, who is the past president of the American Academy of Pediatrics and kind of, in my mind, the mother of childhood obesity. She's been doing this for over 20 years. She started in one of the very first multidisciplinary weight management clinic over 20 years ago. And so they have put out a book on clinical management and childhood obesity for providers. I've also included kind of the systematic review for what effective weight management interventions in children are. So there's a few references, and I thank you for time. Any questions?